All right, I'm giving everybody a chance to get in the room. Thank you so much for joining us tonight for our webinar on pulmonary sarcoidosis and interstitial lung disease. I'm Mindy Buchanan. I'm the Director of Patient Programs here at the Foundation for Sarcoidosis, and I'm going to do a bit of housekeeping, but I first want to thank our sponsor for our educational webinar series, Boehringer Ingelheim. So thank you to them. It makes it possible to do all of our webinars throughout the year. And it's my pleasure to introduce our great panel tonight, starting with Dr. Rahat Hussain from University of Texas. Dr. Hussain, go ahead and get us started.
Well, great. Thank you so
sorry,
much.
I meant to do the, sorry guys, I meant to do the housekeeping. Please put your questions in the Q&A. Gosh, I even had a note for myself. Geez, it's like that kind of day. You'll notice that the chat feature has been turned off for the duration of the webinar. I may chat some information out to you guys if any links are mentioned or anything like that. So you might see some information in the chat, but you're not able to chat back to us. If you have a question, go ahead and submit it through the Q&A function at the bottom of your screen for most people. Sometimes it's at the top, depending on how you run Zoom. And the doctors who are not talking during the presentation may try to answer your questions by typing it in. So if you do type in a question in, make sure to check the answered section to see if your question has been answered. And with that, I will for sure turn it over to Dr. Hussain this time.
Well, thank you very much, Wendy. This is a pleasure to be here. This is actually our second time being invited at FSR, and it's always a pleasure. What we're going to talk about today, I have two great panelists, my colleagues who are here with me, Dr. Pascal Kinga and Dr. Gautam Sika. We are very proud and we're very happy to be a part of this organization. Just to give you a little bit brief background for who we are, we started this Sarcoid Center at the University of Texas in Houston about 3 years ago. And over the course of 3 years, we have increased significantly our patients to close to 200 patients between three of us combined. We are a multidisciplinary group of physicians who not only have pulmonary, all three of us are lung doctors, but we also have cardiology, we also have neurology, we also have rheumatology, skin doctors, eye doctors. As you all know, that sarcoid is a multifaceted disease, and we are very, very happy to provide a comprehensive care for all our patients. And without further ado, I would go into our introductions, and I will, the way that it works is that we will be talking, all three of us will be talking, we all three are lung doctors. Dr. Pascal will start with the introduction of sarcoidosis, then it will be me, I will be talking about how to diagnose sarcoidosis, and a little bit about lung sarcoidosis and stages, and then Dr. Sika would complete the presentation talking about the treatment options, vaccinations, and what is our responsibility as good patients and what are expectations from physicians from us. So having said that, I will have Dr. Pascal go over and start our presentations. Thank you very much. Please go ahead, Dr. Kinga.
Thank you very much. Thank you, Dr. Hussain. Hi to everyone. Basically, I'll be talking more about, let me go to our objectives. Before that, this is just a summary of our contacts, phone numbers, emails. You can reach us through any of those avenues. So our objectives for today, we'll start with the epidemiology, which is basically some information about the statistics and how frequent patients how frequent the disease is. We'll talk about the causes and then clinical presentation, diagnosis and treatment, multidisciplinary care, and patient care as well. So going as far back as in the 1800s, 1877, when Jonathan Hutchison first identified a patient that used to work in a quarry in England, and he saw the skin lesions, and he said they had kind of like at that point, up to that point, escaped spatial recognition. And that was the first time that a physician described changes that we now know as sarcoidosis. So it's a multi-system disorder that is characterized by non-caseating granulomas in the systems that are involved. As Dr. Hussein alluded earlier, we know about multiple systems, the nervous system, the lungs are usually some sort of like the harbinger system of this condition, the liver, lymph nodes, skin. So it's a multi-system disease. It commonly affects young adults. Typically will manifest as a bilateral hilar swelling or lymph nodes, pulmonary changes, which we'll see on chest x-rays, skin, joints, eyes, or also some of the organs that are involved. And the nervous system can be involved in about 5% of the cases in the population. So there's a lot of variability in how frequent sarcoidosis is and how many patients at any time in the population will have sarcoidosis, and it varies by sex, race, and country. In the US, for example, the age-adjusted number of patients that we can see as new patients is around 35.5 per 100,000 blacks and 10.9 per 100,000 in the white population. The highest number of cases that we see, new cases, African-American females aged from 30 to 39 years, of 107 per 100,000 cases. And the overall global prevalence in the United States is 10 to 20 per 100,000. And in Denmark and most of the Scandinavian countries, it's much higher, 50 to 60 per 100,000 in the case of Denmark. So as you can see on this diagram, we just highlight the incident cases per 100,000, much higher in African-American females. And also the next slide is basically the age group that is concerned, 30 to 39 years, much higher incidence. So people usually ask these questions, when I have sarcoidosis, does it mean I have interstitial lung disease? So basically, what is interstitial lung disease? It's just a diffuse, heterogeneous parenchymal lung disease, meaning diseases of the meshwork of the lung. It's classified based on similar clinical presentation, radiographic presentation, as well as pathologic findings as well that we will see on the microscope, and also physical findings that we'll see when we examine the patient. It's clinically characterized by progressive breathlessness on exertion, persistent cough that is non-productive. And there are two major types, those that are associated with a known cause and those that are associated with cause that we don't know, and we call them idiopathic, meaning we don't know what caused it. It's commonly related to environmental exposures. As you'll see in the next slide, we also have the different classes. So how are they classified? So we have what we call diffuse parenchymal lung disease of a known cause. So we know that it could be caused by drugs, it could be caused by other diseases such as rheumatologic disorders. We also know that there's a group of them that are caused by what we don't know, but we just see changes on the CT or imaging studies. So, and then we have what is called granulomatous diffuse parenchymal lung disease, where sarcoidosis is an example. And then we do have other forms of diffuse parenchymal lung diseases, such as lymphangiomyomatosis and pulmonary Langerhans cell histiocytosis. So basically, this means that interstitial lung disease can be caused by so many different things. So if you have if your chest X-ray or your imaging study shows multiple changes, it means it could be caused by just so many different things. Now, what is pulmonary fibrosis or idiopathic pulmonary fibrosis? It is a chronic progressive fibrotic disorder of the lower respiratory tract of unknown cause. We don't know the cause. Commonly affects adults over the age of 40. Most common type is the fibrotic lung disease, commonly termed usual interstitial pneumonia. It occurs due to abnormal proliferation of the meshwork of the lung, followed by fibrosis and disorganized deposition of fibers. And this causes clusters of fibroblasts and myofibroblasts. And this leads to changes on the chest X-ray and imaging studies when the doctors order them. You see significant changes that we call in medical lingua honeycombing, and then you see all these whiteness, these white areas, which we call fibrosis. That's basically what it is. Unfortunately, we don't know it. Now, but if you have sarcoidosis, the question sometimes is that, do I have pulmonary fibrosis or do I have IPF? No, it's different. But sarcoidosis in itself can evolve to pulmonary fibrosis, but it's a different entity from idiopathic pulmonary fibrosis. So what are the causes of sarcoidosis? Unfortunately, we just don't know, but we think and we know that there are certain conditions or certain things or certain exposures that have been associated with sarcoidosis. Now, there is a genetic hypothesis that so many studies have been carried out that show there is a link, but the penetrance is incomplete, meaning that you could have a generation of patients that have the disease and it skips generations and then it shows up after 2 or 3 generations and somebody in the family has sarcoidosis. Now, also infections have been associated with this, and also environmental exposure, like specifically the World Trade Center, people that were firefighters back then in the World Trade Center had sarcoidosis. And also we know of other agents, and especially people working in the auto industry as well. So there's been, in the genetic hypothesis, it's a combination of familial clustering, race, and also gender. So as far as gender, we talk about more females, African-American female, the young age, 30 to 39, and in familial clustering due to genetic exposures. So these are just some of the genetic, these are just numbers and descriptions of particular markers that we can detect if we do genetic studies to identify specific links with that patients with sarcoidosis have. Special association has been reported mostly in Europe, and this was particularly in the Isles of Man, which is a small island between England and Ireland, where you had particular areas where in the city, in parts of the city, you have a lot of people with sarcoidosis. You move a few miles down the road, don't have people with sarcoidosis. So there's this spatial association that has been described as well as occupational clustering. So as we talked about, firefighters, people in auto industry. Also seasonal clustering in some particular countries. In Spain, it was described that it usually used to be common in some particular months, June to July, whereas in Japan, it was usually January, early months in the winter season. So it really has been varying a lot. Now, as far as infective agents, we've been a lot of few viruses have been associated with the mycobacteria as well. So Coxsackie virus, and also Epstein-Barr virus, mycoplasma, and then inorganic agents such as aluminum, zirconium, and talc. Organic agents such as pine tree, pollen, and clay. So I'll end my discussion here. Dr. Sika, Dr. Rahad would take over and hand it over to Dr. Sika to continue.
Great, thank you very much. So now that you have heard the first part, which actually comprised of the introduction, where the sarcoid affects, what is the age limit, and we are going to talk about how does sarcoid really present. And we are also going to talk about where does it present, and I'm going to talk about how does sarcoid present in the lungs. So let me quickly do this and see if you're able to see this now in full screen. All right. So my first of all, anytime when we have a patient who have sarcoidosis, and one of the questions that we did see in the Q&A is that does the sarcoid affect nerves?
Sorry to interrupt. There we go. Now we can see your screen again. It went off for a second, but we're good.
Are we okay now?
Yes, sorry.
Okay, great. So how does sarcoid really presents? The most common presentation for sarcoidosis is in the lungs. If you can see here, they present as a small granulomas. But other than lungs, there are multiple other organs that sarcoidosis presents in, because these granulomas can occur in your brain about 5 to 15% of the time. And when it occurs in the brain, it can affect your nerves, and you can have some neuropathy, we call that. You can have eye problems, which are not very uncommon. We see a lot of eye problems with sarcoidosis that affects your eyesight, and we have to make sure that you have regular appointments with your doctors there. Heart is about 25% and can be a really big deal because your heart function can get low and you can present with palpitations or arrhythmias. If you have sarcoidosis and you're having those symptoms, we need to check your heart. It presents in the kidneys, it presents in the muscles. So people with sarcoidosis present with extreme fatigue, tiredness. And then they also can present with skin changes, especially we call erythema nodosum or nodularity with redness that occurs most likely on the extensor. We call them outside or in your shins. Sometimes it presents very frequently. We see that if it's in the skin. So as a sarcoid physician, if they are evaluating you, they evaluate you from head to toe. Most of the sarcoid doctors are fairly good in making sure that there is no other sarcoidosis present other than in your lungs. But I'm going to talk a little bit more about the lung sarcoidosis because it is one of the most common type of sarcoidosis. A most common scenario that we see in clinics is we have a patient who comes in, they have some nodule or boil or something that they did not notice. And they get a CT scan or something and they get a biopsy and that's someone tells them that you have sarcoidosis and people get afraid. And then you go and read up on the internet and you see it can cause scarring in the lung. And that is why it was important for Dr. Kinga to present that you have a scarring in the lung, but the scarring in the lung that you read on the internet with Dr. Google is actually a lot different than what sarcoidosis actually scarring is. So as I said, these are the areas that are affected. It's a multi-system disease. So as a part of UT Health Center, as a sarcoid center, we have all of these subspecialists who are specially experts in their field. We have a brain specialist, we have a liver specialist, we have a kidney specialist, a heart specialist who actually evaluates you in our clinics, and we have direct contact and communication with them. And unfortunately, because it's a multi-system disease, it needs all minds to sit together and come and formulate a treatment plan for the patients. So how do we diagnose sarcoidosis? Like I presented you guys that, someone gets a chest x-ray or a CT scan for some other reason of the chest, and they tell you, oh, I see these big nodules on the chest x-ray, or you have sarcoidosis. And then obviously this is a term that we have never heard, and all of a sudden we are all scared what this is. So that the primary care doctor orders a CT scan. When they order a CT scan, they see that there are big, what we call in our language, granulomas on the CT chest. And then when we think about granulomas, unfortunately, we go and ask Dr. Google, and Dr. Google tells us, oh, if there is some lymph node on the CT scan, it could be lymphoma. Obviously, then we make sure that that's not the case. Most of the time, it is not lymphoma. So what are these lymph nodes? The lymph nodes are small little, these green dots, as you can see. They help in taking the debris, the extra fluid out from the lungs and the surrounding blood vessels and organs away. And they also harbor the body's immune mechanism and immune system. So they are actually present right around our trachea, which is the windpipe that connects the mouth all the way to the lungs. And when they get bigger, we get concerned that it could be lymphoma, because lymph nodes, when they get bigger, can be a sign of lymphoma, which is a cancer, and obviously a big significant term. We need to make sure you don't have that. So once we get a biopsy, it's not lymphoma, they say it's sarcoid, and then we figure out what sarcoid is. So these are basically body's defense mechanism granulomas, which the body figures out and makes these small little ovoid bodies and gets deposited around the lymph nodes. And if the sarcoid gets significantly worse, it progresses into the lungs, as you can see on the picture on my right. In addition to that, when we see all this, when the doctor tells you that we need to diagnose, you will also be told that we need to do a lymph node biopsies. There are two main important ways. How do you do a lymph node biopsy? One of them, which we use these days, is called an endobronchial ultrasound, or in short, you will see us saying EBUS. EBUS is a kind of a procedure where we take a small little scope. You see this black scope. It goes through your lung, inside your mouth, through your trachea, and we have a small little needle that comes out from this scope, and we take a sample of that lymph node to figure out if this is actually a malignant, a cancer, or not cancer. Because obviously anytime when lymph nodes are big, as I said, then we really worry about cancer, and we need to make sure you don't have that. And if you don't, then these granulomas could be what we call non-caseating granulomas. That's another key term. We'll talk about it in a minute. Then next slide is going to tell you that what is an endobronchial ultrasound. You see this scope. It is a flexible small little scope that goes inside your mouth. These are actually pictures inside your lungs where we go in through this scope. A needle comes out. As you can see, the lymph nodes are typically present around here and around here. We go in with a needle and take these samples and review them and see what kind of cells are growing in there. If we don't have any malignant cells, then we tell the pathologist tells us that this is most likely a granuloma, which is non-cancer, and it could be anything else. Now, what are granulomas? The granulomas that when we get these results are of two main types. One is called a caseating granuloma, and the other one is called a non-caseating granuloma. Most of the sarcoid patients know this term because you have been told that multiple times. Caseating granulomas usually present in infections. If you have had, God forbid, TB, if you have had any other fungal infections, you can have caseating or necrotic granulomas, because remember, we are going into the lymph nodes. These are bodies' protective houses where they are killing these infections if it's the granuloma is caused by an infection. And when there's a lot of killing going on, you can have necrosis inside the lymph node. And that is why when you have a caseating granuloma, we talk about probably an infection and not sarcoidosis. So that's an important term to recognize. So then we say, well, non-caseating granuloma you have on your biopsy, you don't have lymphoma, and then you are referred to people like me and Dr. Sikka and Dr. Kinga, that what to do next. So our job is that, yes, we know that you have non-caseating granuloma. We know that sarcoidosis is one of the disease that causes non-caseating granuloma. But as you can see on the right of my screen, our job is to make sure that we don't miss anything else, which is a reason of non-caseating granulomas in the body. You can see on the right of my screen, these are all the reasons. I don't want you to take a look at them. I'm just wanting you to show them that these are all the reasons that you can have non-caseating granulomas. And yes, this list doesn't end here. There's more. So my job is to make sure you're not on any of these medications, you don't have any other Crohn's disease, you don't have any inflammatory bowel problems, there is no foreign body, rheumatoid arthritis, autoimmune disease, IgG4 hyper syndromes. So this is what we do. So we do a whole complete workup to rule out and make sure that you don't have any of these diseases, because the treatment management can be different. Now, sarcoidosis is usually a self-limiting disease. What that means is not a very aggressive disease. Majority of the patients who have sarcoidosis, they go into remission by themselves. And that is why we also know that sarcoidosis can be a self-limiting disease, but it also can linger on for a long period of time. And that is why if once we found these granulomas, we have to make sure what are the next steps, what stage are you in as far as sarcoidosis is concerned. As we mentioned, that 90% of the time, you may have involvement in the lungs. So after we have completed our autoimmune workup, our infectious workup, our calcium, because calcium metabolism is affected in the granulomas disease, make sure that your bone marrow is okay, make sure your heart is okay. After we have make sure that you don't have any of these symptoms, then we concentrate on your lungs and find out how bad is your lung disease. Now, one of these things that you're looking at on this slide is called the ACE level. Now, this is another lab value that actually gets thrown around very frequently and unfortunately does not have any significant clinical benefit. Sometimes, very rarely, we use it to follow the progression of the disease, but it is not even recommended to do that anymore. So if you have a high ACE level, to be honest with you, that really does not mean a whole lot. And that is one of the things that you may be referred to a sarcoid specialist because you just was found to have a high ACE level. And then usually we follow this algorithm which came out last year. If you have some sarcoidosis that is consistent, your clinical history is consistent, we recommend a biopsy. When we perform a biopsy, we make sure you don't have any other causes, like I mentioned, autoimmune infection causes. And once we have ruled everything out, then we label you as sarcoidosis. Now, sarcoidosis of the lung is divided into these 4 stages, and this is a very nice image that I took from the FSR website. It is a very, very good website to go over and learn about sarcoidosis. So please use your time and go through the website. It's very, very informational. Now, if stage 0 means that you don't have sarcoidosis and you just have some lab abnormalities, that we don't find any granulomas and we don't have any X-ray findings. Sometimes when we get an X-ray, what we figure out that you have some lymph nodes that are involved. It means that your lymph node is positive, and that's it, nothing else. That is called stage 1 sarcoidosis. Most of the time, majority of the cases that I get referred to are stage 1 sarcoidosis or max stage 2, just to make sure that the patients are doing fine. Stage 2 and stage, anytime when the stages are increasing, what that means is that the lymph nodes that I showed you around the trachea, they are sort of diminishing. Those granulomas are going down and they're going into the lungs. As you can see, by stage 2, the sarcoidosis is present in the lungs. The granulomas are present in the lungs and also present on the trachea, on the lymph nodes around the trachea, but they are sort of regressing. As you are advancing in your stage, your lung infiltrates. So infiltrates means that your scarring of the lung is actually getting worse, and you do not have any significant lymph nodes. On stage 3, lymph nodes usually disappear and you have mostly granulomas on your lungs. And stage 4 signifies that you already have developed irreversible scarring of the lung. So it is very prudent for a pulmonologist to go over all these stages with you and figure out which stage you are in. We usually do not start any therapy, and Dr. Sika will talk about when you are in stages 0, 1, or even sometimes 2, there is no clear consensus, but people do start therapy when you are on late stage 3 or stage 4. So those are some of the things that you should know about. I'm putting this picture out there because your physicians may show you this picture and they say, well, this is what's going on. These are 2 lungs, obviously. You have lymph nodes present. These are the lymph nodes that we are talking about. Then you see this whiteness going on the lungs. That's called scarring. That's stage 2 with lung involvement. Then in stage 3, those lymph nodes have gone away and only the scarring remains. And in stage 4, you see that the scarring has gotten much, much worse. So the whiter the black lung is, the worse it is on an X-ray. But in this day and age, we also do CT scan. You may hear a word called HRCT, which stands for high resolution CT scan. And that's an important thing that we do somewhere in patients who are in stage 2 to see how bad the lung involvement is. We also do a test called the lung function test, and we look for a thing called the lung volumes or vital capacities. We want to make sure that you are not very, very restricted. What that means that when you're taking a deep breath, you're not having significant restriction when you're taking deep breaths. So a lung function test a pulmonologist will order for you will be in a box like it's mentioned in this cartoon, and you will be able to figure out what your capacity of the lung is. For example, just like you have an echocardiogram of the heart that tells you what is the function of the heart, the squeeze of the heart, same way, pulmonary function tests are essential to figure out what are the function of your lungs. And last but not the least, we do a 6-minute walk distance, which tells us what is your exercise capacity, how much distance you actually can go. A normal person goes more than 500 meters. We want to make sure that you are getting there or not. If you are having problems with that, what are the reasons? Is it the scarring in the lung? If the scarring in the lung is not there, why your 6-minute walk distance is shortened and stuff. So these are all things that we assess as pulmonologists. Obviously, now it is a multi-system disease, and I'm going to give the podium to Dr. Sika, who's going to talk about treatment. Other than the lungs, you see that there is significant involvement in the in other parts of the lung, and he's going to go over this slide with you guys. And I will stop here. Thank you very much for your attention. Go ahead, Dr. Sika.
I would. Let me just share. That's going to be a challenge here because I'm using a okay. I am so I'm not getting an option to share my screen.
I can run
Dr.
this.
Hussain, can you open the slide deck that I sent you and open up to the PowerPoint, the slide where you just left, the most recent one that I sent you. Maybe you want to open that, and I'll share it and I'll take control.
Can you see my screen?
Not yet. You may have to open up in like presenter's view and then share it maybe.
1 second.
Sure.
Are you able to see my screen now?
No, not yet.
I'll reset the share. Oh, there we go.
Okay.
All right.
I'm going to take control here. Let's see.
Yep. Go ahead, please.
I have control now. Wonderful. First of all, thank you, FSR and my co-panelists, but above all, I really want to thank all the people who've joined in from different parts of US, and I believe some people are also out of coming in from outside of United States here. There's little left for me, but I'm trying to, yes, here we go. So I know that Dr. Hussain did, going back, there's a delay. So I guess I have to work with the delay. Hold on. Dr. Hussain, can you go back to the slide, which, okay, we are unshared again. Sorry, folks. Sorry for the technical issues.
You want me to share the screen?
Can you share it again?
Go ahead.
And go back to the one slide before. I believe I have control, but somehow I lost it. I'm going to request it again once you go back one slide. No, back. Yeah, this is where you can leave. And I'm going to request control again. And I think I have control now. So I'll take care of it now. Okay. So as I was saying, Dr. Hussain did show the diagram on the left side, and I want to really emphasize that it brings me back to the quote that everyone who has sarcoidosis is affected differently, which was said by Karen Duffy, who's an American actress, but also a New York Times bestseller. She's had neurosarcoidosis for a long time, and she's written a few books on sarcoidosis from a patient perspective, living with sarcoidosis. But one thing that quote echoes and this diagram echoes is the fact that sarcoidosis is a multi-organ disease. Now, it can affect one organ or many organs at the same time, but I want everyone to understand the reason why pulmonologists are taking care of this disease more frequently is because 90% of the times lungs are involved. So we kind of have a head start and we want to learn more about it. But if you look to your right, the panel there, it kind of gives you an essence of what other organs can be involved, or in fact are involved. On the top image that shows a little, the A, which says A right here, it is inside of your the airways are windpipe showing endobronchial nodularity consistent with sarcoidosis inside of the airways. This doesn't mean that you have pulmonary sarcoidosis per se, but it can just, decrease air movement in and out through your lungs and cause significant disease there. Right below that, you can see an earlobe swollen up with sarcoidosis. Here there's a nose, very red, involving the bridges of the nose as well. This is called lupus perineo. We see this very frequently, and how bad it looks, we know that it has a good prognosis. We can have someone who has lost a sense of heat and cold. Their nerves are involved, and now they have a little burn right below this image right here. I don't know if you can see my cursor, but this is how it can present. Very frequently see erythema nodosum. Dr. Hussain mentioned that you can have these little red coin-shaped lesions, which are a little raised in the shins. And I've seen so many patients who say, okay, Dr. Sekar, I think my pulmonary symptoms are going to get worse because I've started seeing more and more of these skin lesions. A good marker of activity there. And then, of course, this black and white images of the MRI of the heart showing us some degree of sarcoidosis, which can present with some scarring in the heart seen on an MRI. Now, MRI doesn't tell you if you have sarcoidosis, which is active right now. If I start treating your cardiac sarcoidosis, you may still have some scarring there. And for that reason, you may see that a lot of times we say, okay, we don't need an MRI anymore. We've known that sarcoidosis has been there. So let's order a PET scan to see how active sarcoidosis is in the heart. So cardiac sarcoidosis is, we are recognizing it more and more. We used to think it's less than 10%, and now we know it's about 20 to 30% of the people can have heart involvement at some point in time in their lives. So it's very important to understand the different flavors of sarcoidosis. It can present in one organ, more than one organ, and that actually brings us to how do we treat it? I'm trying to move the slide deck. I'm hoping it moves further. Okay, here we go. So to treat or not to treat, what are the options? And let's look at that. So going back to what Dr. Kinga was mentioning earlier, and this is very important, we know that family members of people who have sarcoidosis have a 3 to 5 times higher chances of developing sarcoidosis. So your genes are playing a big role, but your actual risk of developing the disease is almost always ascertained by an exposure. An exposure can be anything from mold. It can be some infection. We know from the World Trade Center Health Registry that the firefighters fighting on the pile had a 11 times higher risk of developing sarcoidosis. But at the end of the day, it all stems down to not just the exposure, but the duration and intensity of exposure, which culminates with your genetics to move from having the risk of developing sarcoidosis to developing the disease, the phenotype of sarcoidosis. And Dr. Kinga did mention there's so many of the different genes and HLA alleles which are associated with not just the developing of sarcoidosis, but what type of sarcoidosis you have. You have an acute and sarcoidosis which has good prognosis, or something which is a chronic and progressive sarcoidosis. So genes and exposures, intensity of exposure, the type of exposure and duration of exposure, all of these culminate together to give you a phenotype, what we call the type of disease that you're going to get with sarcoidosis. And I think all of this research is done in the last 10 to 20 years, and we've learned so much from it. Moving on. So as I was saying that, so this is a very contingent question that I'm going to pose to you. And I'm sure a lot of people are going to say, oh, my doctor told me that sarcoidosis is an autoimmune disease. And I'm going to say that I kind of differ with people who say it's an autoimmune disease. I think it's a disease which is it's a disease where your immune system is hyperactive rather than autoimmune. Your immune system is so active that things that typically do not cause disease or inflammation, swelling in other people, is causing swelling in people who have, you walking around, get some exposure to the dust. A person who doesn't have sarcoidosis probably will just go through it, maybe cough a little bit, but that's it. But in a person with sarcoidosis, we are going to form this. This is called a granuloma. I hope I still have control. Yes. This is called a granuloma. And what is granuloma? Your immune system is trying to harbor all these antigens, these triggers, and trying to build a wall around it, trying to put little depots of these swellings inside of your body. We call them granulomas. Eventually, these granulomas lead to disease in certain organs. We do have an example of a lung here, but at the end of the day, it can be any organ. We find granulomas in this, as I showed, skin, heart, lungs, brain. But I do want you to understand that this is not a typical autoimmune disease. This is where the immune system is hyperactive. Okay, let's move on to the next slide. Now, okay, here we go. So treatment options. Okay, we move forward. Okay, let me see. Treatment options. So I don't want you to pay attention to the molecular mechanisms here. I deliberately put this slide so the patients can understand what we have achieved in the last 20 years. We've gone from knowing that there's just granuloma development to how it develops. We've understood the molecular mechanisms by which eventually our immune system is able to form these granulomas and cause end organ damage. But we've also understood and learned about learning about these mechanisms. We've learned how to develop therapeutic targets, these drugs that can target individual step to decrease inflammation and decrease granuloma formation. It can be anti-malarial drug like hydroxychloroquine. It can be something which is a disease modifier used in, for example, rheumatoid arthritis like methotrexate. And then we also have some newer drugs which are not listed here, but they've been studied recently, which help clearing granulomas. So I think this is a very exciting time for us in sarcoidosis, and especially for the patients. We have to know that steroids and corticosteroids like prednisone is not the only thing. In fact, we are moving away from that concept that steroids is the mainstay for sarcoidosis. We don't want people to get the side effects of steroids. So we've developed, there's many drugs here and many more coming, targeting this very complex pathway that leads to the formation of granuloma and hence causing end organ damage, such as in this case in the lungs. So this thing is moving slower than I thought. Let's see. I'm trying to move the slide forward. Okay, here we go. So the treatment principle. Hold on. Yeah. So the treatment principle. So me and many others like me and Dr. Kinga, Dr. Hussain, we all believe that the treatment of sarcoidosis is based on a few factors. One is, do you have the disease? Do you have an active disease, and is it a progressive disease? And the degree of immunosuppression depends upon the severity of your symptoms rather than severity of, for example, an image like a chest X-ray. I don't know how this happened. I have to go back. I'm sorry, there's a delay in these slides, and I'm going to try. Okay, we're back again. So as I was saying, that the treatment truly depends upon the severity of your symptoms rather than what an image may look like. A person who only has lymphadenopathy may have more symptoms and require more degree of treatment, or we call immunosuppression, more amount of immunosuppression as compared to somebody who has lymph nodes, but also some scarring of the lungs. And that's totally based on the symptoms of the patients. Some of the other tests like your lung function tests, which are in a way a surrogate of how well your lungs are functioning, not how good or bad your X-ray looks like. And then how many organs are involved. We know that if sometimes when we have organs like brain and heart involved, we need higher immunosuppression. When you have lungs involved, it's very rare you may need more than 20 milligrams of prednisone. I know people think in terms of prednisone equivalence. When I say equivalence, means that I may start you on 20 milligrams of prednisone, but my goal is to bring you down to such a low amount of prednisone that you do not have side effects. And the reason we use corticosteroids first is because there's instant gratification. And why not? We want our patients to feel better sooner. But at the same time, we recognize that corticosteroids can affect your bone health. It can worsen your sleep, your mental health, your diabetes. If you have diabetes, you can get diabetes because of steroids. So there's an array of side effects of corticosteroids we don't want you to deal with. So we try to come down on corticosteroids, typically less than 10 milligrams, which is better tolerated by patients. And if so, we leave patients there. Sometimes we come off medication altogether. But if you see here on this slide, the most important thing is if your disease is diagnosed but not active, you monitor patients. If the disease is active and progressive, then you treat and monitor patients, right? The key aspect is monitor patients. If I take you off the medications thinking that your disease is in remission, it does not mean that you will always be in remission. So it's important to monitor. There's no cure. Think of it like a chronic disease like hypertension and diabetes. We want to treat our patients. We want to treat them with minimum amount of immunosuppression needed for their sarcoidosis. I'm not saying what sarcoidosis you have. You may have sarcoidosis which requires lifelong treatment and high degree of immunosuppression, or you might have one organ involvement. I may be able to come off immunosuppression, but I still need to monitor you. And let's say you are on steroids and I'm unable to come down on steroids. I start you on what we call a steroid sparing agent. I give you a list of those medications in order to come down on steroids. And even when I start you on these medications, I want to monitor you for toxicity. All these drugs can affect your bone marrows. These drugs are bad for your kidneys and livers. So we want to monitor you. If one key theme you have to take from my presentation here is that consider it a chronic disease. You may not have a cure. You may have blood pressure. People have blood pressure and they say, I diet and exercise and my blood pressure is under control, which is fine. You may have a disease like that, but you need to be monitored by your doctor. You need to be owned by your doctor, which brings me to the aspect, Dr. Hussain mentioned that we at UT are striving to build a multidisciplinary clinic. And I'm going to finish very soon, but as long as this slide moves forward. Yeah.
I'll take over the slide. I'll help you with the slide progression. I think I also have some control.
We want to build a clinic around you where we all, all the people who are skilled and have expertise in different organ systems talk to each other about you. So you are always in the center of it, and that's the way to go forward. This is a disease, which is a chronic disease. We need to make sure that people are being taken care of in a multidisciplinary fashion. So what about your participation? It's all, as I said, it's a teamwork, and we have to make sure that we upgrade ourselves. You need to upgrade yourselves. When I say upgrade yourselves, I want you to upgrade yourselves to a better you. We are going through a pandemic right now, but take this as an opportunity, really an opportunity to become physically more active, protect yourself, wash your hands, social distancing, wear a mask, exercise and recondition yourself, stimulate your brain, not with a cell phone. In fact, don't use a cell phone. Don't use a cell phone at night. Sleep well. Sleep is absolutely important to a better tomorrow. So pick a book instead, do some crossword puzzles, but you want to make yourself mentally sharp, physically active, and energetically effervescent. And get vaccinated. I know, and I'm going to come to those slides, we do not have great data in sarcoidosis with COVID-19 vaccine especially, but we know that the benefits outweigh the risks. Knowing that it affects 90% of the people with sarcoidosis have lung involvement, we know that the vaccines have, the benefits of vaccines may outweigh the risk. In fact, there is data, and let me move on to the next slide. Okay, so we have a lot of different vaccines available. In fact, more are available now, but we tend to ask our patients to get a mRNA vaccine, which is a nucleic acid vaccine, whether it's Pfizer or Moderna. And part of it is because there's some data on patients who received vaccines and who are on immunosuppression. Only people who are on mycophenolate or who receive rituximab, and some patients who are on high doses of prednisone do not mount an immune response. But other people, there's great immune response. And then there's also some guidance on when to hold or not to hold medication before and after vaccination. I'm not going to spend time on that, but remember that your doctor, your sarcoidosis doctor should know this already, but also you should be aware that in some cases we have to either hold medication or time medication in such a way that your vaccination immunogenicity is not affected by that. You still mount an immune response to the vaccine. Then, next slide. Here we go. So this is the good news. I'm hoping I had an opportunity to discuss this with the Omicron, the new variant for COVID-19 everybody's scared of. I discussed this with one of our ID doctors yesterday, and he was very optimistic. He said there's little data for now, which is scary, but there's especially little data on severity of illness. It's very contagious. But the good news is that there are two drugs which are on the verge of getting approved. One is ritonavir, which is the Paxlovid, a Pfizer drug, just like Tamiflu, which decreases hospitalization and death by about 90%. And the other one is coming from Merck, which is the Molnupiravir. It's always hard for me to say it, which also decreases hospitalization and death by 50%. In patients who have mild to moderate COVID-19 symptoms. So I think there's a lot of good news. I think the worst is behind us. We don't have to be scared. We just have to, as I said, upgrade ourselves. Moving on to my last couple of slides. Dr. Hussain, I may need your help here. To the next slide. Here we go. So next slide, please. Thank you. So just one back, yeah. So the most important thing, as I said, you sleep well, limit your screen time, get better, get upgraded, but communicate well with your doctor. Activate your MyChart, easiest way to touch base with me, right? Or your doctor for that purpose. Activate your MyChart, know the right numbers for your coordinators and your nursing staff, and call your doctor, especially if you're sick, if you're in another hospital, ER. Doesn't matter. Your sarcoidosis is very important, and it's even more important for you to communicate with your sarcoidosis doctor, especially if you are on immunosuppression. So I think it's important to know your responsibility as well at the same time. And moving on to the last slide here, just to conclude, we all should know that sarcoidosis is a systemic inflammatory disease which is characterized by granulomas. Your genetics and exposures increase your risk of developing the disease. Everyone who has sarcoidosis is affected differently. So every sarcoidosis comes in a different flavor. So do not rely on Dr. Google. Pulmonary disease is the most common disease, but multisystem sarcoidosis, like involving brain and heart and other organs, I got some in the chat box a while ago. There's multiple ways sarcoidosis can present. Biopsy is often required. In very few cases, we don't require a biopsy. A clinical diagnosis can be made, but we tend to go for the lowest hanging fruit. So if you have an axillary lymph node, which will be easier to biopsy, we may do that rather than going into your lungs. And then it's a chronic disease, just like hypertension, just like diabetes, just like high cholesterol. So make sure it's monitored. Unfortunately, there's no cure, but make sure you're monitored so that you don't lose essential time when you're not being treated. It can just present with fatigue, just feeling tired. Let your doctors know about that. And at the end of the day, it's a teamwork. It's a multidisciplinary clinic, and in the center of it is our patient, and that's you. I think that's my time. Thank you.
Okay, guys, thank you so much for the presentation. And I actually am going through the questions here, and some of them we tried answering while you guys were asking, but some of them we didn't. So I will take on the 5 unanswered questions and I'll pose it to Dr. Sika and Dr. Kinga as well, and myself. I'll try to see if I can answer. The first of the questions is from an anonymous attendee who asked, does sarcoidosis progresses or is the initial disease state at the time of diagnosis represent the extent of your disease? In other words, does post-treatment remission mean you will develop new disease somewhere else? That's a really good question. What do you guys think?
So I think the short answer to that is no. If you've been diagnosed with sarcoidosis, a particular phenotype of sarcoidosis, let's say it's a pulmonary phenotype, and we stop your treatment, or let's say you had the inflammation of your spine. Either ways, the data that we have so far, tells us that when people go into remission and they're monitored over time, and if they are to redevelop the disease, it typically develops in the same phenotype. You do not change phenotypes when that happens. So if you are in remission, I think you should monitor yourself, you should be monitored closely. But if you start to develop symptoms again, it will be probably the similar symptoms you had the last time. I do not think people, there's a change in phenotype per se when people, when the disease presents again. But one thing, if you go out of remission, there's a very small chance that you'll go back into remission. Once people are out of remission, they need to be on probably some degree of immunosuppression lifelong. Is that right, Dr. Hussain? You would agree?
Yes, I agree with that sentiment. And on that same note, there's another question on the chat. The question was, I'm in remission and I have been on steroid-sparing therapy. How long will I be on steroid-sparing therapy, or should I continue with that? It's a lifelong thing. So I think on that same regard, your disease needs to be monitored by a specialist, by a pulmonologist or a sarcoid specialist, whoever you are following for that. And if you are in remission, and most of the time, like Dr. Sika said, that disease is like a chronic illness and you need to continue with immunosuppressive agents. The answer to that is yes.
Is this, have you been in remission or you've never been in remission before?
She is in remission. I think they are in remission right now.
If you're in remission, then they should, your medication, it's your either disease activity is controlled that you're on medication right now. So if your doctor thinks you're in remission, that means that you could come off the medication, but monitor it closely. But if you've been in remission before and you're on medication now, it probably will be a long-term thing. That's what I think.
Correct. Is there a climate or area which would be better for someone who has lung sarcoidosis stage 4, Dr. Kinga?
As far as studies go, there is no study specifically telling us whether a particular climate would work for someone. But as I mentioned earlier, the risk of certain exposures, there were some studies that showed that in particular parts of the world, people who had sarcoidosis would manifest more with disease at certain times of the year, like in parts of Europe, or surprisingly in the summer, in the Japanese and Asian areas in the winter months. So those are some of the things that we find in literature, but also in particular avoid these particular exposures that we talked about earlier. If you're a firefighter, you might have to request a change of occupation or maybe some help from your job if they can allow that. Or if you work in the auto industry, you might have to also reconsider your options.
Yeah, I agree with that. I don't think that there's any specific environment. Obviously, there are certain exposures that you want to be very careful about. Dr. Sika, any?
I just want to say, it reminds me of a patient who had to move from an area where there was a lot of farming, used to live on a farm, and developed significant disease. The disease was prevalent in, I think, 3 out of 5 siblings, and they moved to a bigger city, and their disease got better controlled. And this tells us that your exposure might be very specific to you. So you need to know where you are, what are your possible exposures, and perhaps it may take more than this session, maybe a good clinic visit, an hour and a half, talking to your doctor to see how you can be helped with the geography. But I think it's very patient specific as to geography.
The next question I have over here is, someone has sarcoidosis of the heart only and scarring. They are primarily on prednisone therapy. ACE has been coming down. They're asking, other than prednisone that they're on, that they were started at 40 milligrams of prednisone. Now they have slowly tapered it down to 15 milligrams. What other medications are there? I think you have answered that in your slide. Obviously, there are different other kind of steroid sparing agents that are available, even for cardiac sarcoid. That's what we would start over here as well. Methotrexate, Cellcept, and Uran are a few to name that we start here. But again, as we said, please consult with your physicians. These are not, consultations. There might be some significant reasons that you are still on the therapy that you're on. This is an informational sort of a topic that we are here to help. We will not be able to recommend any medications or prescriptions, obviously, because we are here just to give you information. But do talk to your doctor now that you know that there are other options out there, and ask them why they are not prescribing that. Thank you. I'll take
want to mention something here about cardiac sarcoidosis. Two things very important. I personally feel that patients should know about this. One is the definition of cardiac sarcoidosis may actually not only be different in different countries, but even different in different institutions. So the way you were diagnosed with cardiac sarcoidosis, whether it was with an MRI or a PET scan, your doctor really needs to look at the activity of the disease in your heart and determine how much immunosuppression you need for that. There is no one answer to how much one patient versus another need to suppress their cardiac sarcoidosis, but we know that if it is not adequately suppressed, there's a 30% people who have sarcoidosis, cardiac sarcoidosis, there's a 30% risk of development of arrhythmias and sudden cardiac death, which can be, this risk can be averted by EP studies, which is electrophysiology studies, and sometimes placement of things like a defibrillator. And there's some very great data that came out in last 2 years on this that predicts your risk of developing arrhythmias and sudden cardiac death. So don't ignore your cardiac sarcoidosis. If you do have it, you need to be seen by a person who's seen cardiac sarcoidosis before and determine whether you need steroids or something more than steroids. And typically it's we come down on steroids, but something else is almost always needed. And
always for cardiac sarcoidosis.
That's right, Dr.
Yeah, so I still these questions still on coming on, and I know Mindy started her video chat. That's a clue that we are out of time. But I wish I can answer all these questions for you guys. But what we will do is we actually will give you our
emails
and information. And see if we can answer your questions. We are available, all three of us. Our clinics are here in Houston. We are in the medical center at University of Texas. Our informations are there. We would love to help you guys. If you want to reach out to us, please call our numbers, email us, and we'll get you in touch with our clinic coordinators. So thank you very much for your time. Mindy, go ahead, please. I know it's above time.
Oh, it is. But you guys were so great. Thank you all so very much. And just so you guys know, I did take down all the questions that are on the list over here, and can send those on to the panelists. And when I send out the email with the link to the video of this session, we can see if we can have some of those questions answered as well, if you guys are willing to do that. And I'll also include your contact information in that email. So guys, just so everyone knows, you'll be getting an email from me with the links to this video as soon as I've uploaded it to YouTube. It does take usually over the day because it takes a while to upload to YouTube. And any links that we talked about during the session and our panelists' contact information will all be in that email, I promise. I just want to thank everybody for attending. It was a lively crowd. We had a lot of questions and answers done. So thank you. And thank you to our amazing panel. And have a great rest of everybody's week.
Thank you, guys. I really appreciate you guys actually being so interactive. There were more than 65 people logged on, and it was awesome. 74 people logged on at one point. Yeah. So thank you very much for allowing us to participate here. Thank you. Dr.
Mindy,
Sika.
please forward all these questions. I see some great questions that we haven't answered. whether it's the VIP treatment, the vasoactive, and there's many more questions. Just send those questions to us. We'd love to answer those questions.
Yep, I will send them on to you guys.
Thank you. Thank you.
Thanks, guys.
All right, everyone. Thank you so much, Dr. Hussain, for including me. Thank you. Bye-bye.
Thanks a lot, guys. Appreciate it. Bye.
Bye. Bye, Dr.
Bye.
Hussain.
Thank you.